Medicine. Formerly, when religion was strong and science weak, men mistook magic for medicine. Now, when science is strong and religion weak, men mistake medicine for magic. Formerly, a quack was someone who had fake cures for real diseases. Now he is someone who claims to have real cures for fake diseases. Formerly, people were duped by quacks because they believed in their fake cures. Now, they are duped by them because they believe in their fake diseases. Formerly, when our religion was Christianity, we fasted and feasted. Now that it is medicine, we diet and binge. Thus was gluttony replaced by obesity, prayer by psychotherapy, the monastery by the health spa, the clergyman by the clinician, the Vatican by the Food and Dye Administration, and God, for whom being slim meant being virtuous, by medical science, for which it means being healthy. Formerly, when religion ruled the mind of man, people believed in word magic. Prayer possessed boundless power to help man, and blasphemy boundless power to harm him. Today, when medicine rules the mind of man, people believe in drug magic. Medically prescribed chemicals possess boundless powers to cure, and medically prohibited chemicals boundless powers to corrupt. The images of divine and devilish powers have thus remained the same. Only the objects to which they are attributed have changed, from words in the theological state to drugs in the therapeutic state. We call the Pope Pontiff, from the Latin pontifex, or bridge builder, from pons and fissurae, to signify that he is our ultimate bridge from this world to the next. Today, the physician is our pontiff, our bridge from a world without drugs to one with them. The pontifex enabled the dead soul to ascend to heaven. The modem physician enables the sick mind to ascend to health. Thus do we medicalize religion and re-theologize medicine. Medicine cannot give meaning to life, but religion can. The modem tendency to theologize health is a pathetic attempt to cling simultaneously to the practices and promises of both religion and science. Often, the result is that people reap the bitterest fruits of both harvests. What justifies a therapeutic intervention? For the true believer in medicine, the disease, which the alleged patient has. For the medical autocrat, the patient's alleged need for treatment. For the loyal medical agent of the therapeutic state, the government's decision. And for the libertarian, the patient's consent. Ignoring or confusing these conflicting moral and political premises is the source of most of our problems in medical ethics. The most important distinction in the diagnostic vocabulary of medicine is that between symptom and sign. Typically, a symptom, for example, fatigue or pain, is said to be subjective, whereas a sign, for example, fever or high blood pressure, is said to be objective. Although this is a fair approximation to what is at stake here, the subjective-objective dichotomy may mislead. In fact, both symptoms and signs are reports a person makes about a body. A symptom is a report a person, patient, makes about his own body, whereas a sign is a report a person, physician, clinical pathologist, or other expert, makes about the patient's body. Symptoms no less than signs may be true or false. However, a symptom is more likely to be false in the sense that the patient's purpose is to deceive the listener, whereas a sign is more likely to be false in the sense that the reporter has made an unintentional error. For example, a laboratory technician may mix up two blood specimens and thus attribute James's anemia to John, but James is unlikely to erroneously attribute his headache to John, or vice versa. If medical intervention is based on complaint, then the result must be measured in terms of the patient's satisfaction with it, testimonial. On the other hand, if medical intervention is based on lesion, then the result must be measured in terms of the physician's judgment of the effect of the procedure, lesion removal and/or restoration of function. What is wrong with the former standard is exemplified by the fakeries of quacks that satisfy patients. What is wrong with the latter is exemplified by the old witticism that the operation was a success but the patient died. Some people believe that a person should have a right to kill himself, namely, that the intention, or alleged intention, to commit suicide should not be punishable by either the criminal or the mental hygiene law. Others believe that a person should have a right to euthanasia, namely, that a physician, under certain circumstances, should be able to kill a person unrestrained by the criminal law. I support the right to suicide, but not the right to euthanasia. However, I believe there is a right more fundamental than either, namely, the right to self-medication. Thus, the right, say, of a cancer patient to take Laetrile or any other quack medicine seems to me more elementary than his rights to suicide or euthanasia. Yet this is the right physicians are the most eager to deny to patients. A well person who claims to be sick and seeks medical care is said to be neurotic, typically hypochondriacal, whereas a sick person who claims to be well and rejects medical care is said to be psychotic, typically schizophrenic. These judgments reveal the self-interest of the physician. Persons seeking unnecessary medical attention are condemned slightly, whereas those shunning necessary medical attention are condemned severely. In the medical ethic, the greatest crime the patient can commit is to reject the doctor, and the greatest crime the doctor can commit is to acknowledge that the person has a right to reject being a patient. Genuine technical advances in medicine, such as the prevention of water and foodborne infections, prophylactic inoculations, the use of antibiotics, are efficient but undramatic. Soon, people take their benefits for granted. The eradication, in advanced societies, of malaria, typhoid fever, trachoma, diphtheria has not made people happier or more grateful to their culture than they were in the past. In contrast, dramatic medical pseudo-advances, such as lobotomy for curing schizophrenia or transplanting the heart of a monkey into a man for curing heart failure, make people feel elated and impressed with the powers of medical science. This illustrates what the Romans had already clearly recognized, namely, that as soon as people have bread in their stomachs, they rank better circuses above better health. Until recent times, a seriously ill person either recovered or died. Biotechnological advances have created three radically different outcomes of medical treatment and three correspondingly different aims for medical intervention. 1. To enable the patient to live as a socially functioning, self-respecting person. 2. To transform the person into a chronic, professional patient utterly dependent on doctors and others. And 3. To keep the patient alive as a quasi-cadaver on which physicians and medical technicians demonstrate their ability to keep organs and tissues alive. Although no contemporary textbook of pathology mentions the word schizophrenia, much less recognizes or describes it as a disease. And although medical researchers are ostensibly busying themselves trying to demonstrate that the misbehaviors psychiatrists call schizophrenia is a disease, the United States government accepts it not only as a disease, but as a disease susceptible to drug treatment. On October 20th, 1989, American Medical News reported that the Food and Drug Administration has announced approval of the use of a highly toxic drug to treat severe schizophrenia. The drug, clozapine, was approved for use in patients who have not responded to at least 2 regimens of less toxic therapy. Patients suffering the torments of intractable pain due to terminal cancer who want heroin cannot get it, because the United States government does not recognize heroin as a treatment. Patients infected with the HIV virus, suffering the agonies of having an apparently untreatable illness who want drugs used abroad to treat AIDS, cannot get them, because the FDA does not recognize such drugs as legitimate treatments. But individuals who do not want clozapine can get clozapine and get it whether they want it or not. This seeming paradox is emblematic of the politicization of modern American medicine. Paid by the state, the physician has rejected the idea that the aim of medicine is to succor the patient as a suffering person and moral agent, and has embraced instead the idea that its aim is to treat an alleged disease, according to the rules laid down for it by government bureaucrats. In America today, the United States government, not medical science, defines what is, and what is not, a disease or a treatment. If you free a person of his obligation to pay for his treatment, you also deprive him of his right to define what constitutes treatment. Collectivistic planners for healthcare services, acting in defiance of the proverbial rule that lie who pays the piper calls the tune, may sow the wind of medical idealism, but reap the whirlwind of medical indifference, or worse. Today, everyone claims to be working for the patient's best interests. No wonder the patient is in deep trouble. The greatest analgesic, soporific, stimulant, tranquilizer, narcotic, and to some extent even antibiotic known to medical science, in short, The closest thing to a genuine panacea is work.